I am deeply appreciative to the organizers of this meeting for having me again, and it's a pleasure to be here. So, approach to cardiogenic shock, tailored escalation of support, I think makes sense for a couple of reasons. Here are my disclosures. So, as I was putting this talk together, I thought to myself, rather than think about this in terms of, numbers and flows and so forth, because let's be very honest, outside of this room, nobody's putting in PA catheters, all right? This just in. We take transfers from Wisconsin, we take transfers from all over Chicago, all over Indiana. I would say that people come with balloon pumps and Impellas, sub 20% actually come with a PA catheter and ever had a PA catheter during their hospital course. So we think about this in terms of phenotypes. We got a couple of common patterns here, okay? We've got acute presentation, no prior history of shock, subacute presentation, where I think a lot of the money is, and subacute presentation, and perhaps they've done this before. So the first group of patients, cardiac arrest patients, STEMI, mixed shock, massive PE, VT storm, post-cardiotomy, very, very dramatic population of patients. And so when my LifeNet app goes off and I see the CCG, I know what we're in store for. I'm delighted that Dr. Carr referenced the kitchen sink. The kitchen sink is at the bottom of the slide. And so pretty much everything has been thrown at this patient, even after getting ROSC. But I think a lot of the money is in the patients that are languishing on the floor. We're always sort of grasping at positive pieces of data and ignoring the negative pieces of data, and these patients are sort of spiraling. And this is a lot of them. There's an overlay of valvular heart disease or recent ischemic insults and so forth. So there are certainly some patients that get into trouble because of iatrogenic overaggressive up-titration of guideline-directed therapies. And unfortunately, these patients are frequently recognized in this phase when, in fact, they should be recognized ideally in this phase when escalation can actually help them. And that's certainly true of patients with a known diagnosis of HFrEF that are here for as a bridge to therapy or bridge to decision, and the intermax slope is indeed pretty slippery. Many of these patients who start off as intermax 3 or 4 quickly slide back to intermax 1, even under our watchful eye. So conventional parameters for navigating are shown here, have been shown over and over in this conference. But if you want to sort of take a deep dive, there's lots of directly measured hemodynamic parameters that we could navigate by, and derived hemodynamic parameters that we can navigate by. But again, these are woefully underutilized in the community. And when we receive these patients, I think it behooves us to get an objective assessment. We've talked in this meeting about CPO and PAPI as very important newer hemodynamic parameters, not really newer in the sense that CPO has been known for a long time as a very robust predictor of outcomes in the absence of mechanical circulatory support, but recently been adopted. There are other risk metrics. This is the IABP Shock 2 score. That shows that there are 3 very distinct populations in IABP Shock 2. This has been validated prospectively as well. This is the derivation set. The validation set showed more or less the same thing. As you stratify these patients, you find that there are 3 very different groups of patients. So timing and escalation of support. The ideal target window here is at the top of this spiral, not at the bottom of the spiral, but unfortunately that's frequently when patients are thinking about being escalated. Initial bedside assessment and stratification on a very prosaic level can happen like this, but I think that as we think about minutes to days, unfortunately, MCS frequently gets relegated to the bottom of that pathway and should perhaps be bumped up. This slide has already been shown. I think it's important to recognize that vasoactives are not a great way to buy back pressure and output. And really, once you get past low-dose vasoactives, you're dealing with an exponential increase in mortality. So goals of MCS in early implementation: decrease preload, decrease afterload, augment CPO and power, and bridge patients to recovery, decision, durable VAD, and transplant. And certainly there are lots of different mechanistic ways, either by themselves or in combination. Dr. Burkhoff has already elegantly detailed the fact that how you get your pressure and flow back is very different between these different devices. And I think that this is a fundamental concept, not for this room, but for everybody else in the community. I'd remind you that 2019 statistics tell us that there are 6,200 hospitals in this country. 5,250 of them are community hospitals. All right? Take 620 off the top as non-federal psychiatric hospitals. you're left with a lot of community hospitals that don't understand the difference between this. And it's not a knock against community hospitals. I think, a rising tide raises all ships, and we should all sort of aspire to understand what Dr. Burkhoff has laid out. So the Detroit Cardiogenic Shock Initiative, I think, is a very visible and a very promising view. Certainly there's some criticisms that could be levied against this, but I think it's important to recognize that CPO becomes front and center, regaining cardiac output the right way early on in these patients. The knock, of course, has been everybody has a LVEDP greater than 15 when they're coming in with a STEMI. That's fair, but I think that many of those patients are destined to keep sliding in the wrong direction. As you know, Impella in this capacity has improved CPO, and compared to historical controls or historical reference, the outcomes, the survival to discharge, are very promising, and that's been upheld in the National Cardiogenic Shock Initiative. But the ground level reality within institutions, including my own, is a little bit different than that. This is data that we presented at TCT just a few months ago, looking at 127 consecutive Impella cases at our institution, representing a couple of years for us. These are not folks that were shipped in on Impella. These are not folks that got surgical implants. These are all percutaneous Impellas. The majority of them are CP cases, stratified into 4 different groups: cardiac arrest, out-of-hospital cardiac arrest, cardiogenic shock, ACS, AMI, and high-risk PCI and VT ablation. And you can see that those 4 curves stratify out very nicely, unfortunately. The third curve is cardiogenic shock mortality without cardiac arrest, and 58% mortality at 30 days. So we're certainly not quite there in terms of early implantation and early escalation of therapies, and there's a lot of truth to what Dr. Carr said. Our in-house escalation plan is a work in progress, but this is certainly a good one to sort of template off of. This and several others are what we're sort of basing ourselves off of. It's beyond the scope of time to go through this in detail, but step 1, objective assessment, stabilize, and perform complete revascularization when feasible. Step 2 is critically important. You've sort of breathed a sigh of relief, you've gotten the vessel open, but you got to reassess and see if you're still on the right track after revascularization. As Dr. Kumar presented the case a few minutes ago, lots of things go sideways even after a successful revascularization. And then finally, escalation for higher level of care very early on. Table your ego, even if you're a high volume community center, is the message, and say if you can't offer advanced therapies with a comprehensive shock approach and advanced heart failure, transplant, VAD, and so forth, you need to think about passing that ball to somebody else. So in summary, there's a wide spectrum of presentation acuity and complexity that really defies a single treatment algorithm. Objective assessment and getting patients off of pressors becomes the initiative. However, you do that with mechanical circulatory support and then repeated assessments early on. So I'm not knocking the fire all your guns approach first, but I think that firing your guns early and in a targeted fashion probably is what makes sense. Thank you so much.
So we have a little time for discussion. So, I mean, the real question is, how do you find that equipoise point? Top down, bottom up. And then the third axis you mentioned is the cardioeconomic angle. Can you comment on that? I mean, you have tremendous results. You both do. And, you still have some mortality. On the other hand, you're spending a lot of money. How do we find the right point?
I haven't found it. When you found it, let me know, because I think my center single-handedly is bankrupting Medicare, and I want to make sure that we don't do that. I think this is, whenever you talk about benefits, someone has to talk about costs. We as physicians don't like to talk about costs. We think we are scientists and we take care of patients, and whatever we can do, we'll do for the patient. But when you start getting into population health and management and using your resources, I think we have to get most bang for the buck that we have. Resources are not unlimited. So we are making baby steps to understand shock. This is one of the endeavors, and I think many other, Detroit shock and all those things are doing. Once we have a better understanding of the device, we can tailor devices properly and intervene hopefully earlier so that patients don't get to the stage where we have to throw the kitchen sink at them.
So let's talk about cost, because there's nothing more expensive than a patient that languishes and dies, right? So the thing of it is, you, both JK and Sandeep, have made me feel very good about the fact that we've started a very aggressive protocol, much to the chagrin of the surgeons in my institution, to where we go straight to the cath lab for early assessment as to whether or not they can respond to drugs or need mechanical circulatory support, which in our institution, in the hands of our cardiologist, seems to be ECMO, with no collusion on my part. But the point is, the early assessment and early activation of essentially an MI protocol is what you guys are really espousing, both of you. And I applaud you for that. Because then the patient either responds, which we've learned happens, or they don't, and then you don't get yourself in this spiral of a long languish because you've already pulled your trigger early.
No, I agree with all the points that were made. I think the challenge is, to really look at the patient objectively and say that, as much as you want to believe that your revasc has done the right thing and the patients are moving in the right direction, if they're not actually moving in the right direction, you got to make a move. And so frequently, the call will come in at 6 or 7 in the morning rather than at 1 or 2 in the morning that, actually their lactate's gone back up, And so I think that's the trap. And, at that point, if you're already sort of, behind the 8 ball, you go to the cath lab, you fire all your guns, and you're still going to languish. You're still going to be spinning your wheels for a while. I think the other piece of this is also, resource utilization. We have a busy lab, and we don't have enough cath labs. We've got 4 places to work within our institution to accomplish about 3,500 cases. We need 2 more cath labs. And so a lot of these cases are very labor-intensive and resource-intensive cases, and having a dedicated space to do these kinds of cases is something that we're, in very deliberate discussions about, to basically designate a lab, similar to a trauma OR that's always open. There's always 1 trauma OR open in our institution. 1 out of 30 is designated as a trauma OR that is always open, and then whatever else needs to be done. Similar to that, having a suite, and it doesn't have to be a high-end suite, right? To put in MCS, you need a camera, you need some toys, right? Designating, repurposing some of the spaces that already exist in our institution so that there isn't that delay is something that we're talking about.
First of all, I think I'm a little jealous of Detroit. It looks like it's the birthplace of early goal-directed therapy. As you all know, Manny Rivers' paper for early goal-directed therapy in sepsis with shock was really well received initially, right? I mean, impressive numbers. And now we have controversies about that because, how did they reach that mortality benefit and everything else? So, but cardiologists, you guys have spent billions compared to the pulmonary critical care physicians in terms of the trials.
Trying to spend trillions.
Right? Exactly. But what we have in the sepsis world is we are not having norepinephrine compete with dopamine. So we're coming back to the cardioeconomics angle. Unless we have true randomized controlled trials where you're going Impella versus Tandem versus Acpella and all of these under one umbrella, we're going to be sitting here 10 years from now having the same discussion. And so I applaud the efforts of the Cardiogenic, the shock initiative. We're looking forward to it. But I do feel like you guys will be in the same spot we are in the sepsis world right now, where we're just saying, early goal-directed therapy, it was great, and it's really being the best clinician at the bedside that matters. Just some lessons from critical care world, and thank you, Dr. Carr, for recognizing the 1 out of 6 critical care physicians in the room. Like, I think we're a small minority, but as cardiologists, basically work with us more, we hope that we can improve this lactate clearance and the oxygen debt.
All right, let's wrap it there.
Yeah. Are there any other comments? I was really enamored by the Manny Rivers story with goal-directed therapy, and I thought that we as cardiologists were way behind time. And it's so obvious that we should have been in a GDT kind of environment much earlier. But now that story is a little bit unraveling has unraveled, I guess, in pulmonary care. But still, I think that we have, since we are primarily dealing with a hemodynamic problem at the earliest stages, and it really gets down to time. I think every single person, I don't think anyone disagrees with the time element here. And that's really the issue, because you go from a hemodynamic, imagine you have a patient who has in front of your eyes an MI and lose function, and you put that in, and you restore hemodynamics, the rest of the body wouldn't know, right, that there was any problem. You'd still have microcirculatory function, you'd have end organ function, But now, as time goes by, this switches to a completely different disease, in essence. So, Eddie, one last comment.
Something that Jay said really struck me in terms of the timing the patient languishes in the hospital. And if you extend that time to their outpatient for the survivors, it strikes a note. We have a recovery clinic that we started about a year ago for decannulated ECMO and recovery from shock patients. And it's important because these patients were showing up back in our hospital, back in shock 2 or 3 weeks later when you didn't know what was going to happen to these guys. So I've learned a lot from that clinic. One thing I've learned is that rate that was put by, I think Sachin put up that rate of 25 or 50%, 25% of patients come back in heart failure. Those are the ones that don't die at home. I think it's a much higher figure. And I want to say that that is a real goal. If you're going to do a cost-benefit analysis, let's really get to the cost-benefit.
The only one thing I will maybe say in closing is that the issue of randomized trials in cardiogenic shock, I think not going to happen in the US. And we really, I think, are going to have to rely on our European colleagues who have alternate means of informed consent. I think that's the issue, is informed consent. And in Europe, they're able to do this with a retrospective type of informed consent, which is we really don't have that. Formally we have that, but it's very difficult to implement here in the United States. So.
I completely agree. In the last 10 years, I've been going back and forth with FDA to try to do a cardiogenic shock. And the biggest problem was what you just outlined. But I think there is hope. The two things FDA had proposed. One was to use similar patients with hemodynamics across the country, maybe across the line in Canada, and compare them to a similar cohort of patients, how we intervene in US, and use that as a control. But more importantly is now there are 4 or 5 centers developing a cardiogenic shock score. And that will be validated prospectively in mortality. And once we have a score of cardiogenic shock, then it'll be a little easier to homogenize the field and then have therapies. And I think it's moving in the right direction. There is obviously not enough data, but a lot of centers are pushing. And I think in the next 2 to 3 years, we will have a surrogate cohort in another country, and we'll have a cardiogenic shock score, which has been validated. That will open the doors for randomized trials here. Otherwise, it'll be impossible to do.
And just the last point, I think, to all these points, that's where we have to start. But again, to Dan's comment, it's not as clean as even that was portrayed, because people come in with baggage. And that goes back to the sort of the A and B classification of these pre-events. Not everybody comes in the same, where the body wouldn't even know if you changed the pump out transiently. No, because they have all types of early metabolic issues. And I think until we get the description of those variables on top of the hemodynamics, we're still going to be in this kind of morass, because we're always going to say, well, they were an exception. They're not an exception. They have those other parameters. We just don't have those defined right now to kind of move forward.